Glucose control in critically ill patients has a checkered history, with several conflicting reports published in the literature. Let's take a quick look at the latest study in this area, in this episode of Osler Shortcuts. Blood glucose management in the ICU has long been a topic of intense debate, starting with the study by Burghe van Burghe in 2001. Some studies suggest benefits of tight control, while others indicate potential harm. This inconsistency might arise from differences in early parenteral nutrition use and instances of insulin-induced severe hypoglycemia. To explore this issue, a new study by van Burghe's group has been published in the New England Journal of Medicine. Over 9,000 ICU patients were randomly assigned to two groups. The first group received liberal glucose control, where insulin was introduced only when blood glucose levels went above 215 milligrams per deciliter. The second group was under tight glucose control, aiming for blood glucose levels between 80 to 110 milligrams per deciliter using a specific computer-controlled algorithm. Parenteral nutrition was not allowed during the first week of care. The median morning blood glucose level for the liberal control group was 140 milligrams per deciliter, while the tight control group had a level of 107 milligrams per deciliter. Not surprisingly, instances of severe hypoglycemia were slightly higher in the tight control group. However, interestingly, the rate was extremely low at around 1% of patients, which is much lower than previous studies. The results? When it came to the primary outcome, the duration of ICU care, there was no significant difference between the two groups. The 90-day mortality rates were also similar. This effect was similar across subgroups, including cardiothoracic surgical patients, a group in whom benefit had previously been shown. Secondary outcomes revealed that while most parameters like new infections, respiratory support duration, and hospital discharge times were consistent between the groups, tight glucose control seemed to have a protective effect against severe acute kidney injury and cholestatic liver dysfunction, though this should be regarded as hypothesis generating. The Tgc Fast trial is a methodologically sound study which adds confidence to its conclusions. So, what does this mean for clinicians? Despite incredibly safe provision of tight glycemic control, which is unlikely to be replicated in the real world, the investigators could not show a benefit. As such, it seems hard to continue to implement this practice. If you'd like to know more, why not head over to Osler and read one of our extensive library of journal reviews. Like all Osler content and features, they are completely free. See you next time on Osler Shortcuts.